Namaskar, this is Dr. Anurag Agrawal and today we are going to talk about the cancer pain and its interventional pain management through the means of MIPSI, that is minimally invasive pain and spine interventions of pain medicine, a new super specialty, emerging super specialty of anesthesiology which deals exclusively with the chronic pain syndromes of all kind including the cancer pain. So, I am working at a pain physician and professor in anesthesiology department at Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow, Uttar Pradesh, Bharat. I have done my MBBS from GSVM Kanpur and MD anesthesiology from SNMC Agra as well as PDCC course in pain medicine from Banaras Hindu University. My area of interest is interventional pain and spine medicine as well as the percutaneous spine endoscopy. I am Vice President of NAPCAM UP chapter, also the founder president of ESIPS, that is the first endoscopic spine and interventional pain society of India. I am a member of pain medicine board of the National Board of Examinations for Medical Sciences NBEMS, a Government of India autonomous statutory body, and I am a member of Cancer Aid Society Ethics Committee. Also, I am the secretary of Indian Society of Pain Clinicians, and this is Indian Society of Pain Clinicians is the body of formally trained pain physicians in India who has done at least PDCC or FNB or DM pain medicine course. So, to disclaimer, I have no financial relationship with any manufacturing company or pharmaceutical company. Consent have been taken from the patient to use their photos and videos for the academic purposes only, and mention of trade name is purely for the sake of clarification and simplicity to understand. So, to etiology of cancer pain, as we know that incidence of cancer pain is up to 90% in the patients who are surviving with the advanced stages of cancer. So, there can be multiple causes. It can be because of the cancer itself, which may result in the visceral pain, somatic pain or neuropathic pain. It can be caused by the cancer pain which is post surgical or due to the chemotherapy or due to the radiation therapy of the cancer treatment. And then there can be patients who have pain because of the conditions causes unrelated to cancer. Like a patient of cancer can also have a prolapsed intravertebral disc which may demand their treatment. So, cancer pain is highly prevalent. 30 to 50% of patients of cancer who are in the active therapy, they experience chronic unrelenting severe pain which needs to be managed, and up to 90% of patients who are in the advanced diseases where the curative therapies are over or are not working, they are in the chronic severe intractable pain which must be addressed to enhance the quality of life, to preserve the dignity in the end of life, and you need to may need to refer this patient to a specialized pain medicine OPD and a pain physician nearby to your place. So, classification of cancer pain can be done into the somatic cancer pain, like the pain which have patients are having bone metastasis, they have that somatic kind of pain. Then it can be visceral pain like in the gallbladder cancer or the pancreas cancer. Then it can be neuropathic pain like in the carcinoma lung involving the brachial plexus or the group of nerves or post herpetic neuralgia. And then there can be the reflex sympathetic dystrophy, sympathetically mediated pain like it happens in the phantom limb syndromes. So, there is a baseline pain. As I told you that cancer, especially in the advanced condition, is not likely to go away. So, when the disease is there, pain is also to be there. It is not like something acute event like there is a fracture, you fix it and after 3 months pain is gone, fracture is healed, but that is unfortunately not the case with the chronic pain conditions like the cancer itself, where pain is going to remain. So, you need to give a baseline therapy, round the clock therapy to cover the baseline pain. And then there can be a pain which is breakthrough in nature, which is over and above the baseline pain and which may be related to some activity, like the patient of oral cavity can have severe pain while attempting to eat something. Patient of carcinoma rectal canal can have severe pain which is over and above the baseline pain when he tries to defecate. So, what can we do as a society? What can we do as a medical practitioner? What can we do as a pain physician? So, what I can tell you, sympathy is not enough. Just to sympathize, oh, patient is having so much of pain, patient is having, that is not going to work. We have to do something proactively, and what I can tell you what we need to do proactively. So, first thing, if you want to address a problem, you need to assess the magnitude of the problem, and what are the scales available, that is the numeric rating scale, visual analog scale or descriptive scale. Like numeric rating scale, it is a very simple scale to use, they are most commonly used by a pain physician to assess the quantity of pain, because you ask the patient how much pain you are having on the scale of 0 to 100 or 0 to 10. If the patient says 0, that means patient is not having any pain. If the patient says 100 or 10 on a scale of 0 to 10, patient is having most severe kind of pain and you need to treat it. Then whenever you provide any treatment as a treatment provider, you need to find out the outcome measures. There is no point of treating a patient if you are not finding out whether it is working or not, your treatment is working or not. So, what are the scales? There are pain intensity scale, again the numeric rating scale or visual analog scale you use. You ask the patient, after my treatment how much relief you are having, what are the signs of distress, have they come down, what is the relief and what is the breakthrough dosing. So, the aim of any treatment, especially in the chronic pain medicine, you need to optimize the pain control, you need to minimize the side effects, otherwise what will happen, patient is not going to comply with your advice, and you need to take care of the cost also, and the aim is to increase the functional abilities and to enhance the quality of life. So, what are the modalities of treatment for the cancer pain management? Pharmacological approaches, we have a separate lecture on that, you can go through the website to find that lecture. Minimally invasive pain intervention, MIPCs, and neurosurgical interventions, cryoanalgesia, long term epidural and implantable devices, we will show you later, implantable pumps, and then there are other therapies. So, there is a ladder of analgesics which was proposed and popularized by the World Health Organization, where they suggested to start the treatment of any chronic pain, especially the cancer pain, with the easiest of available drugs which are available over the counter, which are having less side effects, less cost and easily administrable. And what are these drugs? Commonly known as Brufen, Diclofenac, aspirin, paracetamol. All these drugs, they can be used in the first step of the ladder if the patient is having mild pain. On the scale of 1 to 10, patient is telling that my pain is only 2 or 3, then you can start with the first step ladder. But what if the patient says no, my pain is 5, which increases up to 7, so that comes under the category of moderate pain, and you need to step up your drugs with the non-opioids, that is NSAIDs, that is Brufen or Diclofenac as an example, along with some weak opioid drugs. What are the weak opioids commonly used? Codeine and tramadol in our country. And what if the patient says I am having 8 or 10 out of 10 pain, I am having the worst kind of pain, then you directly go to the third step of the ladder, which includes the prescription of strong opioids like the oral morphine tablets, and that is the cheapest and easily prescribable thing, but they are controlled subject. So, you need to have some center nearby you, or you need to refer the patient to get this step 3 ladder, but you should know. Then there was a fourth step which was suggested by later on to include the MIPC, minimally invasive pain and spine interventions. At any step of this ladder, if you feel that you can do or you know someone who can do an effective intervention for your patient which may decrease the requirement of opioids in your patient, that it is amazing. So, that intervention part can be used and should be used perhaps in most of the patient if the facilities are available, a trained pain physician is around, and you can refer the patient to get the benefit of this advanced therapy. So, what are the interventions I am talking about? So, the target, the aim of intervention is to there are two aim. One is to delivery of opioids to the CNS so that the dose reduces drastically. Suppose you are giving oral tablet, so you need to give a lot of drug in comparison to what you require to give if you are directly delivering it to the spinal cord. So the dose become drastically reduced if you are able to deliver that drug directly to the spinal cord where it is going to ultimately work, or there can be ways to destruct the pain pathways. So that is the intervention. So what are the pain pathway destruction? This is reserved for the advanced cancer patients where the life expectancy is low. The aim is just to enhance the quality of life, to decrease the doses of drugs and their side effects, and patient is having severe localized pain. So there are multiple targets in the human body given by the God, which we pain physician target in the percutaneous minimally invasive manner to destruct that thing, like start from the thalamus to cervical cordotomy at different places, dorsal root rhizotomy and all that. So what are the common targets which we pain physician target? That is, one is the most common is trigeminal neuralgia, especially useful for the oral cancer patients. Even after the surgery or radiation or chemotherapy, if the patient is having severe pain, we go into the Meckel's cave under a C-arm fluoroscope guidance in a dedicated pain medicine OT, and we target the gastrin ganglion and we do the radio frequency treatment of that. The result is that patient's requirement of analgesic drugs usually comes down drastically. Patient gets immediate and long term pain relief. Then comes the celiac plexus, a wonderful intervention for the upper abdominal malignancy patient like the cancer of gallbladder, cancer of lower part of stomach, cancer of pancreas, and they can be targeted. Then in the lower part of abdomen, cancer of uterus, cancer of cervical cervix, cancer of anal canal, they causes severe lower abdominal pain, and that can be relieved with the help of superior hypogastric plexus rhizolysis. And then cancer of anal canal, cancer of rectum, they also respond to the ganglion impar. So the celiac plexus destruction, it is situated in front of aorta at the level of L1, and it is very useful intervention for the upper abdominal visceral pain due to gallbladder cancer, pancreas cancer, stomach and lower part of esophagus cancer, and up to 85% patient they report of wonderful pain relief after that. Then superior hypogastric plexus, as I told, it is in the lower part of abdomen in front of the spine. We pain physicians use a C-arm fluoroscope and X-ray machine in a pain medicine OT, and we target this plexus, and this results in a wonderful pain relief in the patients of carcinoma of bladder, urinary bladder, prostate, cervix, uterus, ovary and colon. Then comes the ganglion impar, again minimally invasive intervention, no big incision, no big admission, no long term admission in the hospital, and patient gets better with the CA rectum, anal canal and vagina vulva cancer patients. Then comes the most advanced treatment for the bone metastatic pain. When there is a metastasis, that means the spread of cancer to the bone, we pain physicians are able to do a percutaneous cementoplasty in these patients, and these patients are usually unresponsive to conventional pharmaco and radiation therapy. Please remember, radiation is considered to be the most first line treatment for the bone metastatic patient, but unfortunately it does not work for all. It does work, it takes up to 6 weeks to work, and if after 6 weeks there is no relief, it is not going to be relieved. So what we do, that we stabilize the bone with the metastasis with the percutaneous delivery of bone specialized bone cement, that is PMMA cement, and most commonly we treat the vertebral metastasis with kyphoplasty and vertebroplasty. So here you can see that there is a patient who had collapse of vertebra, and we have gone inside with our fine equipment under the C-arm fluoroscope picture, and we have finally achieved the filling of vertebra, stabilization of vertebra with the cement and with the immediate relief. Then comes the intrathecal morphine pump for cancer pain. Amazing treatment, and here you can see this is one of our patient. We use a very fine catheter to deliver the medicine directly to the spinal cord, and we fill this pump with the morphine drug morphine injection, place it under the skin in the lower part of abdomen. Here you can see that patient, this catheter is going into the spine, and this is the catheter. This is a pump which is filled with the morphine. The most amazing part is that this particular patient was on 150 milligram of oral morphine per day, 150, and currently through this pump this patient is only on 0.6 milligram morphine in 24 hours. So, you can see the drastic reduction of morphine doses to the patient with immediate and wonderful relief and with almost non-existent side effects. While when patient was on the oral morphine, patient was having severe nausea, vomiting, severe constipation. For that we were giving lot of medicine, different medicine, but now he is free of all medicines. This pump is continuously working by itself. Every 4 months patient comes to us, we refill it without any incision in a percutaneous manner through an injection, and patient goes back. So, at our institute of Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow, at Pain Medicine OPD, what we are providing? We are providing acute pain services for our inpatients. We are providing pain medicine OPD, where we are treating all kind of chronic pain patients, including the low back pain, spine pain, vertebral fractures, neuralgic pain, trigeminal neuralgia, post-herpetic neuralgia, joint pain, arthralgias, arthritis, rheumatological diseases, and all kind of different and difficult pain syndromes, even after the pain after the spine surgery and after the total knee replacement, with the most advanced MIPCs like the radiofrequency ablation, cooled radiofrequency ablation, pulse radiofrequency ablation, intrathecal pumps, spinal cord stimulator, vertebral stent. Like this is something new for you guys, I believe. Like we put the stent in the heart for the heart condition, now we are able to put the stent in the vertebral body to stabilize it. That is the most advanced treatment of the India of the world, and which we are able to provide to our patients. And you will be happy on this here note to notice that in pain medicine we are no less than anyone across the globe. So, you should be proud of it. Cancer pain we are also treating. So, most of the cancer pain patients are managed with the WHO ladder, but multiple MAPCs are available which can be helpful, and then pumps. And for interventional therapies we are doing neck pain, back pain, spine pain with the epidurals, transfemoral, facet denervation with radiofrequency and other things, sacroiliac joint rhizolysis, MIPCs. For trigeminal neuralgia, gastric ganglion, glossopharyngeal neuralgia, sphenopalatine, lumbar sympathectomies for Buerger's disease and all that. And for sympathetic MIPC cancer, non-cancer patients start from the striate ganglion rhizolysis to lumbar sympathectomies, to celiac rhizolysis, splanchnic rhizolysis, hypogastric, ganglion impar, all these. So, now a few case reports. This was a female, she was post surgery, post CT scan, post radiotherapy of carcinoma cervix with locally invasive tumor and metastasis. She complained of severe pelvic visceral pain, not relieved with multiple analgesic like tramadol and morphine, and we did superior hypogastric plexus rhizolysis with phenol, and now patient has come down to the step 1 of WHO ladder. From she was not relieved with step 3. After the intervention, she is stable at step 1 with aceclofenac only. So, this is the picture of real patient, where you can see that our fine cannulas has gone inside the patient ahead of the spine, and we have put some dye to localize the area, and then we did the rhizolysis. Another patient, she was 55-year female, back pain with no radiation, sitting intolerance, and on X-ray we found that she had a fracture of D12 vertebra and abnormal shadow, that was metastasis at her hip bone, that is sacrum, and on MRI the diagnosis was confirmed. And here you can see that in the MRI of picture you can see that this is collapsed D12 vertebra, and also at the sacrum you can see that is a fill up of metastatic lesion. So, we did a complete workup. She was unresponsive to the WHO ladder. We did a percutaneous vertebroplasty as well as a percutaneous sacroplasty, and her pain was completely relieved. So, you can see that there is a bone cement in the sacrum, left side of sacrum, as well as bone cement in the D12 vertebra, and she was completely relieved without any big incision, without any hospital stay. Now, another patient, he was a patient of carcinoma lung, and which was involving the brachial plexus, which is the group of nerves which supplies the upper arm, upper limb. Here you can see on the CT scan the huge tumor on the left side of lung with the severe pain, most severe pain, and we did a high cervical chordotomy of this patient at C0 C1 level, that is the most advanced intervention to the date, and very few people in India and globe practice it. We fortunately do, thanks to our teachers and Bhagwan Almighty, we are able to help our patients. Here you can see our fine cannula is going into the spinal cord actually, and we target the lateral spinothalamic tract with the radio frequency of this thing. So, the end point is that not everyone can bear pain, so please treat it. Ours, Bharat, India is a land of sages, big sages who can bear pain. We have a story of Bhishma Pitama who laid on the multiple spikes, but not everybody can treat it. So, please treat it as a doctor. So, and freedom from pain is a basic human right, and this is my institute, Dr. Ram Manohar Lohia Institute of Medical Sciences. As I told you earlier, I am a pain physician and a professor of anesthesiology. We run a pain medicine OPD and a pain medicine ward and pain medicine OT. We do all kind of advanced MIPCs and comprehensive care for all type of chronic pain patients. We urge all the people listening to it who are from the anesthesiology background, if you are interested in the field of pain medicine, we are having PDCC 1-year course at our institute. You can visit the website of institute Dr. Ram Manohar, drrmlims.ac.in to find out about it. You can also join us for the observership of 1 to 3 months at our institute if you are interested in the pain medicine. So, with these words, good luck and good wishes from my institute, that is Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow. I am having my Facebook page with the name of Pain Free India / Dr. Anurag Agrawal, as well as a YouTube channel with the name of Pain Free India, and where I put lot of videos of the procedures, MIPCs, as well as of the different testimonials of the patients for the awareness purposes only about the availability of most advanced treatment for the chronic pain syndrome. So, please use it, please visit, and thank you and good luck for your bright future. Thank you.